Special technique demonstration of pneumothorax. Pneumothorax may occur following trauma, tension, pneumothorax, or in patient with a COPD or asthma. Whole X-ray, body X-ray should be done to reveal air in the pleural space. The skin over the neck and area chest should initially be palpated for evidence of crepitus and soft tissue emphysema, which may give a clue and associated pneumothorax. Skin and subcutaneous tissues are reflected from the chest wall. Being careful not to open to the pleural cavity. Care should be taken not to puncture the intercostal soft muscles, soft tissues, penetrate the pleural space as this releases air from an underlying pneumothorax and makes subsequent demonstration impossible. Reflect a chest flap up to the mid-axillary line. Pour water into the angle between the subcutaneous fat tissue and the chest wall. Pierce intercostal tissues below the water line with a blade. If pneumothorax is present, a bubble of air will be seen rising through the water. Alternate method. Done before any incision are made. Introduce a wide bore needle attached to 50 ml water filled with a syringe into the subcutaneous tissue over an intercostal space. The plunger should be removed previously. The needle is pushed deep to enter the pleural space and water watched for the presence of any bubbles. A similar procedure is then followed on the other side. Next is demonstration of air embolism. In both arterial and venous embolism, take a X-ray and CT scan of the whole body. If venous embolism is suspected, abdomen opened before any other cavity. Abdominal contents are moved gently out of the way to inspect the inferior vena cava closely for bubbles in the lumen through its transparent wall. Water may be filled up in the abdominal cavity so that inferior vena cava drowns under water. Incise inferior vena cava carefully to see if air bubbles escape. Opening the chest, care should be taken to avoid pulling the sternum and ribs to avoid creating negative pressure in the tissue may result in sucking in of air causing artifactal air embolism. Postmortem demonstration of venous embolism. Air in the right ventricle can be shown. The sternum is removed by dividing the ribs, being careful not to puncture the pericardial sac. The internal mammary vessel ascending the aorta, inferior vena cava are clamped to prevent escape of air from heart into these vessels. Pericardium is opened anteriorly and its edges grasped with the hemostat on either side by an assistant and lifted up. This will create a small sac. Inspect external epicardial vein for evidence of intraluminal bubbles. In case of air bubble, they present a beaded appearance with numerous air bubbles along the length. Water is then poured into the sac. Once the sac is full of water, the coronary arteries are incised and massaged. Escape of gas bubbles noted. Air in arteries indicate systemic embolism. Next, right atrium and ventricle is incised with a scalpel. If no bubbles escape, twist the scalpel a few times. If air is present, bubbles would escape. If it can be collected in measuring jar rods, volume noted. Demonstration of venous embolism. Skin is incised for exposure. The heart, rib cage and sternum removed. Pericardial sac filled with water and a graduated cylinder containing water inverted over it. Right side of the heart punctured. The scalpel, if air present in the heart, it will rise up to the cylinder. Diagrammatic representation to show how air enters the graduated cylinder with a right heart is punctured. Alternatively, a water-filled 50 ml syringe minus plunger is connected to a wide bore needle and inserted into the right ventricle. If air is present, it will be seen a syringe chamber. Pyrogalol test. Bacteria may produce gas within the right heart very soon after death, even in the absence of any visible sign of putrefaction, which may mimic air embolism. This can be distinguished with the pyrogalol test principle. True air embolism contains air with the oxygen, while putrefactive gas will not contain any oxygen. Alkaline solution of pyrogalol. A strong colorless reducing agent turns purple in presence of oxygen. Procedure. 4 ml of 2% of freshly prepared pyrogal solution is collected in a 2 ml syringe into 10 ml syringes. First syringe add 4 drops of 0.5 milliliter sodium hydroxide to make it alkaline. Introduce into right ventricle. Aspirated gas taken out. Remove needle. Seal needle with an end with a stopper. Shake in a case of true embolism where there will be oxygen and mixture would turn purple, otherwise not. Second syringe. Function assess control. Introduce some atmospheric air untested as a do. Should turn brown in all cases. Alternative technique useful if facilities of underwater exploration are not there. An autopsy surgeon is inexperienced. Frothy blood. Simply lift the heart in situ, cut apex with a knife and look inside left ventricle. If it contains frothy blood, it indicates air embolism. Other condition presenting with a frothy blood, careless handling of the heart before it is opened, putrefaction. Flotation in water, it has been suggested that all great vessels of the heart are ligated and heart removed, then it will be float in water if it contains air. It's like a Breslow second life test for stomach and intestine in infanticide. Source of air should be determined as far as possible. If source of air in the neck vein, stab wound of the neck, air can be demonstrated in superior vena cava. If pregnant uterus in the large pelvic vein and inferior vena cava, composition of air should be determined by removing air with a syringe and subjecting into gas chromatography, mass spectroscopy. More than 95% of nitrogen indicates nitrogen narcosis. If air embolism is suspected, heart should be opened first. Examine surface vessels of the core gas bubbles. There should be prominent and definite segmental breakup of blood in the vessel with a collapsed segment in between. Any may represent artifact. Ophthalmoscopy of air bubbles in retinal vessel may require corneal moistening with isotonic saline to prevent interference from corneal opaqueness. Postmortem demonstration of air embolism. Internal carotid artery, basilar artery are ligated before removal of brain. Skull vault removed without damaging the meninges. Examine the meningeal vessels for visible air bubbles. If meningeal vessels are damaged during removal of the scalp cap, air bubbles may appear an artifact. Submerge a brain in water, release ligature at the vessels, compress them slightly, watch for air bubbles. An airtight water-filled gas syringe with a needle can be used to collect gas from heart vessels, heart or cavities. Demonstration of air embolism, dissect pulmonary artery underwater, note escape of fat droplets. Thank you.